In this module, I'd like to discuss rhythm control strategies for atrial fibrillation and how your choice of a drug might be affected related to adverse events that may occur from these drugs and specifically end organ toxicity. If one looks at the European and American guidelines and looks at drugs, for example, that are recommended front line, these are often not recommended because they're more effective drugs. They're recommended because they're safer drugs. So let's take a few examples. If we look at patients with lone atrial fibrillation with no structural heart disease, the guidelines recommend flecainide, propafenone, and sotalol in the old guidelines. We'll get to dronedarone in a second as frontline therapies. Why were these drugs recommended? They work half the time. They essentially have no end organ toxicity. Their only toxicity is some subjective nuisance, adverse events, and in the case of sotalol, very rare occurrence of torsade de pointe. However, you would notice in the guidelines that flecainide and propafenone are not included at all in patients with significant structural heart disease. This is based on the fact that in post-myocardial infarction patients with depressed ejection fractions, flecainide has a high incidence of causing ventricular proarrhythmia and actually may worsen survival. So you could see how the guidelines and their recommendations may be altered by not only the safety of a drug, but the safety of a drug in a given population. Now, the drug that has the most significant end organ toxicity is the drug that's most commonly used for atrial fibrillation. That is amiodarone. Amiodarone has a significant occurrence of causing liver function test abnormalities, pulmonary fibrosis, neurologic issues, and because every 200 milligram tablet of amiodarone has 75 milligrams of iodine, it raises havoc with thyroid metabolism. There are also corneal microdeposits that can occur, and so any patient that winds up on amiodarone, there's a chronic vigilance that's part of that therapy. So that although amiodarone works in 2/3 of patients where other drug works in half of patients, working defined as suppressing atrial fibrillation recurrences, it has a lot of potential for end organ toxicity, and the drug is usually reserved as a second option. And you could see in all the guidelines, this was actually reduced as a secondary option, except for in heart failure, where there's very little choice except for dofetilide. Now, dronedarone had been recommended as a frontline therapy, except for in patients with heart failure, based on a similar safety profile. The drug had been very well studied for years, including the Athena trial. There was no evidence of thyroid abnormalities. The drug does prolong the QT like amiodarone, but essentially torsade de pointe is shorter case reportable. It does slow heart rate a little bit. The main subjective side effect is that about 1 in 15 patients may have to stop the drug for diarrhea. So a drug that could be used as an outpatient with a low proarrhythmic profile has made this drug quite popular. Recently, there's been 2 cases of idiosyncratic liver failure with the use of dronedarone. Whether this is related to the use of the drug or not is not completely clear. There were no signals of major changes in liver function tests in the hundreds of thousands of patients that have otherwise been treated, whether they were in controlled trials or post-market release. Would this has raised the issue that with this drug, should liver function test monitoring be part of using the drug, and would this drug have been recommended frontline as vigorously as it had if this data had been known at the time of the guideline reading? I'm not sure I have the answers to that, but I think in my own practice, we are at least aware that this is a potential issue. We are now discussing with our patients that this could be an issue. In the United States, a little different than Europe, there's a recommendation of being aware of this issue in periodic liver function monitoring. My own personal bias at this time is it's a little bit like finding a needle in the haystack, and that to order a lot of tests where we're not going to find anything is probably a little bit of a waste of time. But I think that the regulatory bodies have appropriately given us some advice on how to manage this. This is a little different than in Europe, that based on some recommendations there, liver function monitoring is going to be now part of their package label. So there'll be a little difference on how the drug's used in different sides of the ocean. I do think that this will suppress a little bit of the use of the drug, but to put things in some perspective, we're still not sure whether the drug caused these 2 cases of liver failure. They both went on to have liver transplantation. We know that monitoring is probably not going to help in a lot of patients in finding this. I do think that we're more aware of this, at least potential, and I think the drug will be used with appropriate caution.